Good afternoon, Nursing 303 students. We are on part 4 of chapter 69. This must be the longest chapter in this book. So this will be the final part 4, and I will have it up on for week 9 today. This is Monday. So we're on page 1129 in your book. Your book, the slide for this was a little bit out of order, out of sequence. So I'm going to be starting by talking about, this is intrauterine disorders, and then we have congenital, and then we also have acquired infections. So when we talk about intrauterine disorders, what it's something in the uterus, something's going on there. We talk about that is usually from congenital factors or perhaps acquired intrauterine problems. Remember, when we talk about a congenital disorder for a newborn, or we could also say with a fetus sometimes, but it's anything that is abnormal with the fetus, with the newborn, that exists at birth regardless of the cause of it. So it could be something that has gone wrong back during the embryo stage, could be an infection, could be something going on with the heart, could be something, trauma during the birth process. So if it exists at birth, then it can be called a congenital disorder. So when we do talk about acquired disorders, so something that the newborn or the fetus acquires, we could think of the mother is taking perhaps medications, prescription or otherwise, or using drugs, alcohol, whatever they are taking, it has caused problems with the fetus growing in the uterus. So when we talk about teratogenic problems, we're talking about something that is causing a disorder of the fetus when it is in the uterus. So we've talked about some of these already, but when we talk about teratogenic disorders, something that can harm the fetus, interfere with it growing, interfere with the way that it should be developing. Sometimes it's a matter of the patient, the mother, getting sick. Maybe she gets the flu. Maybe that affects the baby. Maybe she gets an infection. And like I said, drugs, alcohol, tobacco, other things like that. In fact, when the patient goes in, let's say to have some work done on her teeth, don't they even then say, is there any chance you might be pregnant before they do x-rays? Excuse me. So we talked about rubella also, rubella. A woman coming into contact with rubella, pregnant. There's a very, very high chance, high probability that the newborn will have some abnormalities, such as cataracts. So that would affect the vision, brain damage, deafness. So there's also, when we talked about congenital heart defects, which can be slight and maybe not causing a problem, or could be very serious. Okay, once again, I want to bring up iatrogenic issues. Probably the one that would be not the most common, but perhaps one of the most serious. What about giving oxygen to a baby and thinking of what that might do to the retina of the eye? So others, like, what if There was one baby that had an infection, and the staff, because of what bad aseptic technique, gave it to another baby. What if they had to use forceps, and that caused a problem, which we've gone over some of those. So we will start in on this PowerPoint right here and talk about the fetal alcohol spectrum disorder. Spectrum, they like to use that word now on different things like autism spectrum. So going from perhaps very serious to, mild, and they can talk about the spectrum. So not all fetuses, newborns, children are affected the same by some of these. So fetal alcohol spectrum disorders. Sometimes it's also referred to as fetal alcohol syndrome. And if the mother drinks during pregnancy, anywhere from hardly nothing at all to very much indulging, they don't really have a number there. They don't know how this is really going to affect the baby. Could be slight, like I said, it could be serious. It may or may not reflect the amount of alcohol that the mother takes in. So maternal use of alcohol is a major factor. It says when we talk about fetal physical defects, when we talk about behavioral problems, learning difficulties, there's also other things such as growth deficiency, not growing at the same rate as other children, microcephaly. So what are we talking about? Small head, small brain, facial abnormalities, and actually your book lists what a child with fetal alcohol syndrome might look like, because there are some definite facial abnormalities. Can also have problems with the heart and even mental retardation. So spectrum could be something that's barely noticeable to something very noticeable, very serious, even something that might cause death. So no safe levels of alcohol intake. Advise pregnant women to stop drinking before they get pregnant. So next one we have down here is Down syndrome. I think one or two of you did a paper on this, very nice paper. Actually, I also had one or two of you that did a paper on the fetal alcohol syndrome. So I learned a lot too. It was, it was your papers were very good. Yeah, I really enjoyed reading your papers. So if you haven't done yours yet, yes, do it. Okay, so Down syndrome, it said it is commonly identified in the newborn nursery. It's quite often identified right at birth. They may know before birth, right? Different tests they can do. So if you saw a baby and it had the characteristic features of Down syndrome, the only way that they can really be sure and give that diagnosis is what? They need to analyze the chromosomes to see if that is indeed what it appears to be. So once again, this can be from mild to severe. And like I say, quite often when we see the word syndrome, it involves many different aspects, but it also usually does have from mild to severe, or somewhere in there, mild to moderate or moderate to severe. So some of the things they're just saying that may indicate that a newborn has Down syndrome would be a deep crease runs horizontally across the hands. So you would actually be able to look at the palm of the hand and you would see a deep crease running across it horizontally. And I actually was present in one of my clinicals. So I did see a newborn with this crease, and it was quite easy to see. It says the eyes are slanted, may not be quite as noticeable on a newborn depending on the birth and if they had to use forceps and the molding of the head and so on. But the eyes are slanted and the tongue is large and protruding. The infant is flaccid. What does that mean, flaccid? No muscle tone. And they say usually the newborn will also have mental retardation and heart defects, perhaps cataracts and GI disorders. And you remember when we talk about GI disorders, that can be anywhere from the mouth to the anus, anywhere in anywhere in that tube. That is the GI system. Okay, going on to acquired infections. So we have TORCH for this on page 1129, TORCH. So this is supposed to help you, what is an acronym? Help you remember what these are. So these are the most common and the most serious high-risk infections. So the mother is pregnant and hopefully she does not come in contact with any of these organisms because obviously they can affect the fetus. So both the mother would have this infection, which may or may not be a problem for her. But these almost always, yes, are a problem for the fetus. So this is a reminder of the most serious infections. Number one there, we have what? Toxoplasmosis. I can't remember when or what term that you probably first heard about this. Toxoplasmosis. And maybe this is the first time you've heard of it. It's a protozoa. What does that mean? It's little, it's not a bacteria, it's not a virus, it's not a fungus, it's a protozoa. What is a protozoa? Just a small little creature. Okay, protozoa. Where could you get this? If you own a cat and you're the one in charge of cleaning out the cat litter, well, that might be where you could get it. If you are in charge of cooking meals and you decide to skimp on cooking the meat well, that could be where you could get it, undercooked meat. You decide to go out and dig around in the garden and plant some, yeah, you could get it from the soil. So toxoplasmosis, it is around. So think of then cat feces, somebody else gets to clean the litter box for what, 9 months? Rare meat, raw meat, but it can also just be in the soil. So wearing gloves also would be something you could teach. So usually when people get this, or often, they do not have any symptoms. They don't even know they have the infection. But what could it do to the fetus? Stillborn, a stillborn newborn. So it can be very serious. Can mean that mother goes into labor early. So we've got a premature baby. Another one, microcephaly. What does that mean? Micro, small brain vault, small brain, small head. Hydrocephaly. Is this just the opposite? So sometimes you'll hear it called water on the brain. Hydrocephaly, what do they need to do? Put in some shunts. Seizures, mental retardation. So you can see this can be very serious. So on this one, it says they have a nursing alert kind of in here. It just says that infections can be transmitted to nursing personnel from what? From the newborn. So standard precautions, isolation, etc. But you already know that. Okay, toxoplasmosis, that's the T. And remember, it's a protozoa. Then we immediately go to other. I'm going to go to the ones that are not the others yet and go to R for rubella. I think you've heard of that, rubella. I've mentioned it several times. It is a virus. So we've heard a lot about viruses lately. It is a virus and it causes the measles, a particular kind of measles, and we call them the German measles. German measles, rubella, very, very serious. This one is so serious that if a woman comes in contact with it, sometimes the woman will opt to have an abortion because it is so likely that her fetus will be affected by this, infected, affected. So rubella, German measles, 3-day measles, it's a virus. The woman that catches it, not a big deal. So she gets the 3-day measles, okay? But the effect on the fetus, I don't know exactly what the statistics are, but very, very likely to cause problems. So these fetal defects, we call that congenital rubella syndrome. Once again, when we have a syndrome, it usually means more than one thing. So what would be some of the perhaps effects of this on the newborn, on the fetus, if the mother came in contact with rubella, had an infection? So cataracts, deafness, congenital heart defects, cardiac disease, and mental retardation. So it says the concerns regarding this have increased because what? Are people going in? Are they taking their children in and getting immunizations? So MMR, that's one of the immunizations, right? That stands for measles, mumps, and rubella. So if there is somebody walking around that has not had their immunizations, their MMR, and the pregnant woman comes in contact with them and becomes infected with rubella because perhaps she hasn't had her immunizations. Anyway, so serious. That's why it would be nice to have this set up before somebody gets pregnant, so they already have immunizations. Although you can't just get immunized and then get pregnant right afterwards. So we'll, I believe, talk about that also. Okay, cytomegalovirus. Okay, this one tells you right there that it's a virus, right on the end of it. Cytomegalo, must be a big virus, megalo. So what does this belong to? The herpes group. Herpes is not our friend, is it? So many of these viruses that cause problems for us are in the herpes group. So it does say that a woman that might be asymptomatic, meaning what, she is not having any symptoms, can pass this to her fetus through the placenta. She doesn't even know she has it. Cytomegalovirus. If she does not pass it to the fetus through the placenta, it could be that through the delivery process, coming in contact through the delivery, that she could give it to her newborn. So possible effects on the newborn, what could this be? So let's say that the newborn does come in contact with it, not the newborn, sorry, the fetus does come in contact with it when it is in the uterus. It could be small for gestational age. So it's born and it's like really small. Oh, wow, this is like a 35-week baby and it's small. Microcephaly, hydrocephaly, mental retardation. So this is serious, right? Cytomegalovirus. Remember, it's a virus. It's in the herpes family. So far we've got toxoplasmosis, rubella, and cytomegalovirus. We have one more on here. The H would have to be herpes, right? Herpes simplex virus. But we have other herpes viruses. But this one they're talking about is herpes simplex. This is the one that we hear about all the time. People, what, they get cold sores, they go out in the sun and get them. We usually think of having these cold sores, what, kind of around the lips, mucous membranes. So this can be herpes simplex virus type 1 and type 2. And remember, genital herpes can show up, you know, they can go opposite places. So any of the herpes simplex viruses can cause harm to a newborn. So neonatal herpes may be fatal for a newborn. So what if you don't have the blisters, whether it's type 1 or type 2, so you don't even know that you have it? You may not be thinking about the birth process and whether cesarean would be better. So unless they do lab tests, they can't differentiate between type 1 and type 2. So if a woman was pregnant, let's say she's 14 weeks long, and she became infected with this, there's a good chance that she might have a miscarriage. Of course, we call that a what? Spontaneous abortion, because the baby did become infected, and probably it could be that it would not be, its condition would not be compatible with life. If the herpes virus type 2 is acquired later in the pregnancy, it's very dangerous to the fetus. So what can it do? We know that it can cause spontaneous abortion. So what else? What else could it do? It says it could cause premature labor. So hopefully not too premature, right? But we don't want any babies born prematurely. What about a local infection? That's kind of what adults get, right? Herpes simplex, a local infection of this on the outer part of the body. But in this case, it could be an infection of the eyes, the skin, or the mucous membranes. So premature labor or local infection of the eyes, skin, and mucous membranes. So if the mother is getting close to the point where she's going to give birth, they usually do cesarean delivery just so that the newborn is not in contact with this. So if they were going to do cesarean and then they find out that the amniotic fluid is already contaminated with it, then they go ahead and do vaginal birth because it's too late then. It's already come in contact with it. So the newborn would be isolated from other newborns if it had come in contact with herpes simplex virus. Okay, so up on the top there, we had other. That was the second one, other. What does it have? It has syphilis. I think that, is that spelled right? Syphilis, I guess it is, okay. Hepatitis, we know about hepatitis, right? And herpes zoster. So I guess they couldn't make up a word with all of those, so they just put other. There's also gonorrhea, HIV, AIDS. Actually, there's more than this. Let's see. Okay, we'll just kind of talk about this a little bit. Actually, I'm going to go to this one. No. Oh yeah, okay. I guess this is the next one that they talk about before. Okay, so some of these infections, it says and STDs, sexually transmitted diseases. I know they don't call it that anymore. They have a kinder word. Okay, they can be life-threatening, or what? The problems from this, the effect of this can be lifelong. So gonorrhea, we think of that as a fairly common sexually transmitted disease. What do they do? That's right, the newborn. Aren't they doing something to keep this from getting in the newborn's eyes? Yes, we talked about that. You're taking some ointment. Was it erythromycin? And because if the mother had gonorrhea and the baby comes in contact with this, um, it could cause bilateral conjunctivitis, eyelid inflammation. So it can also cause then blindness, ophthalmia neonatorum. So prophylactic antibiotic ointment. Law requires this in every state. Gonorrhea is very, very common. So why not do this to every newborn to keep them from going blind? So if they do get it, then obviously they are also isolated from others. Okay, what about syphilis? So it used to be that before anybody could even get married, they had to be tested for syphilis years ago. Yes, I know, because I was married many, many, many years ago. So it does say in most states, there's a law that requires testing of pregnant women for syphilis. This is a pretty serious infection, right? So if the woman does have syphilis, then she can be treated with penicillin and everything will hopefully be okay. She's treated, she's over the infection. But what if she does not get treated, does not go in, does not get tested? It says then untreated syphilis can lead to premature labor and delivery. Okay, so you have a preemie baby. So what are the complications though for the baby if the mother does have syphilis, which then the newborn acquires this also? They could have infection, they could have defects, and they could be born dead. So syphilis is nothing that somebody would want to take a chance on. It needs to be diagnosed. It needs to be, the mother needs to take antibiotics. So what if the baby was born and it did have syphilis and somehow nobody noticed it and you were the one looking at it? What would make you think, oh, I wonder if this baby has syphilis? So your book is kind of interesting because they give some signs and symptoms, mainly signs. General skin eruptions of rose spots. Eruptions of rose spots, that kind of like a rash. Blebs or blisters on the soles and palms. So hands and feet, the bottom. So blebs or blisters. Snuffles. What are snuffles? And it just means a discharge from the nose, like a lot, like diarrhea of the nose mucous membranes, but it's not diarrhea. But they call it snuffles. A hoarse cry, crack. I think this cracks and ulcerations around the anus and the mouth. Cracks and ulcerations, and a positive blood test. So give antibiotics, isolate them, and so on. So remember that there would be something. There would be that kind of a rash. Would be the blisters on the soles and on the palms of the hands. And what? A runny nose, very much runny nose. Okay. HIV and AIDS. So we know that if a pregnant woman was infected with HIV or had AIDS, but infected with HIV, whichever, if it had progressed to be called AIDS, it would still be the same, the same virus. So HIV can be transmitted during pregnancy via the placenta, also during delivery or afterwards through breastfeeding. So women that have been diagnosed that are infected, they can take treatment during the pregnancy and also after the birth. So if they do take this, it is much less likely that the newborn will be positive for HIV. So not every pregnant woman that is HIV positive is going to give birth to an HIV positive baby. But like I say, they can start treatment. Another one that we have down here, I guess I'll bring it up because it says thrush. Thrush. Is that a yeast infection? And we think of the mouth, right? Thrush, the mouth. So we're talking about the baby still. If the baby has thrush, what are you going to see? We're going to see what? White spots in the newborn's mouth. And they're saying that if the mother has it, it can be transmitted to the baby. And this would be during delivery also. So thrush. And even though it is a yeast infection, remember yeasts are actually fungi. So infected newborn, once again, isolated, and they treat the newborn with nystatin. Okay, you already know you have to have clean equipment, you have to have good hand washing. And they say wiping the newborn's mouth with a gauze sponge after each feeding. They mean the inside of it? Yeah, inside the mouth. Wipe out the mouth with a gauze sponge. Why would we be doing that? What would that have to do with having a yeast infection in the mouth, with having thrush? And it does say because lactose, does that sound familiar? That's milk sugar, lactose, promotes the growth of this. And so if you wipe the mouth out, hopefully you're removing some of the lactose. It used to be that they would give a little bit of water in a bottle also to kind of clean that out. Okay, we're getting there. We're actually onto something now that you can actually think about and envision or look at pictures of. We're talking about musculoskeletal disorders of the newborn. This is on pages 1130 to 1131. Okay, so let's talk about this. We'll get through this fairly quickly. This is mainly just talking about what it is. A fracture, we all know what a fracture is. It has to do with the bones, right? It says they may occur at birth. Baby wouldn't really get a fracture until birth, but why would they get a fracture? So maybe a really quick birth, a really long birth, a torturous birth, a baby just won't come out. So the ones that they're talking about, like a fractured clavicle. What's the clavicle? What's that? Would that perhaps happen during the birth, that it just, like I say, perhaps the passage, when we talk about the passenger or the passage wasn't big enough for the passenger. And it says that they usually heal without problems. So fracture of the clavicle is a fairly common one. We usually call that what? The collarbone? The collarbones? Okay, but clavicle is the real name. So let's just say that that did happen. Okay, so let's picture a baby just lying down. It would be on its back, right? And let's say that it had a fractured clavicle. So now I want you to go up and kind of poke at the baby gently, but poke at it enough to kind of startle it. We call that the startle reflex or the Moro reflex. So the little legs should be drawn up, is that right? And what's going to happen to the arms? Shouldn't they kind of go up like, you know, is that one arm or both arms, depending on, you know, where this is fractured? Would the side where the fracture is, would that arm go up? Would it cry when it moved it? So just thinking about that. So signs and symptoms of a fractured clavicle include asymmetric, remember that means without symmetry. In other words, they're different, not together. Asymmetric Moro reflex and crying when the affected arm is moved. You go to put on this little t-shirt and it cries because you just moved the arm that is on that side where the clavicle is. Okay, talipes, what's this? Clubfoot. Occurs more often in boys. What is a clubfoot? Can they have it in both feet? Yes, they can. So they're just saying that they turn out of the normal position. So what can they do? Exercises for this. They can do corrective shoes, brace, casts, surgery, depending on how bad it is. Next one we have is dysplasia of the hip. So what does it say there? Congenital, meaning they're born this way, dislocated hip. So you've already had your AMP, thinking about where the femur is attached to the body. They're saying this one is more frequent in girls. So what? Faulty embryonic development of the hip joint. So congenital dislocated, and it does say developmental dysplasia of the hip. If this happened during the birth process, then it wouldn't be developmental dysplasia of the hip. Okay, so the hip joint is unstable, instable, and what are they going to have to do? They're saying the head of the femur does not sit securely in the acetabulum. They need to do something. They need to keep it in place. So every infant is checked for this. They usually use x-rays to see if this is really what's going on. So different things they can do. Remember in an adult, when an adult gets a new hip, what do? They don't want that side to what? Cross over the midline. So there's some things that they do to keep things in place until it heals. So in this one, they're just saying they could use a triple diaper. So this is going to force the leg into abduction. And maybe they'll even use a cast. So just so that you know, dysplasia of the hip. Polydactylism and syndactylism. We're talking about what? Fingers and toes. Poly, too many fingers or toes, and syndactylism, what? Fusing together, webbed, we could say. So sometimes when we talk about an extra finger or toe, it's just like a little, almost like a skin tag. They may leave these, but it depends, or they can remove it. And like I say, syndactylism is webbing or fusing together. So they can do this surgery to free those up. So I said that was easy. Next one we have is nervous system disorders. And we've talked about these: hydrocephalus, spina bifida, anencephaly, and microcephaly. These are neural tube defects. When we talk about neural tube defects, the neural tube, remember, is what goes into being the brain and the spinal cord and so on. So neural tube defects, they are congenital disorders. And these are disorders that are related to genetic abnormalities as one. They could be related to teratogenic drugs. They could be related to environmental toxins. So they're related to something that has affected the development of the neural tube or the neurons in the brain of the baby, of the fetus. So something has caused a problem. So like we say, usually the neural tube, what we're talking about, neural tube defects, that usually develops into the spinal cord, and the neurons develop into the brain, and something has happened. So we talked about folic acid. I think that was week 1. In fact, I think that was when we actually had class, folic acid. Somebody's thinking about getting pregnant. Do they have to take a certain amount of folic acid? And then after they are pregnant, they take even more of it. So just that's kind of one of the things there. There's different diagnostic tests if they suspect this or want to identify, if this is happening. So we're going to look at some of these. First one we have is hydrocephalus. Cerebrospinal fluid. So we have that in the brain, is that right? And it also goes down into the so okay, I'll start that over, sorry. Cerebrospinal fluid, I guess if we look at that name, cerebro, brain, spinal cord, is in the ventricles of the brain. It's also in the subarachnoid spaces of the brain. So if you have too much fluid and you are little like this, tiny, what is going to happen? It is going to what? Be pushing out. The head is going to get bigger. When you have pressure on the brain, does that lead to brain damage? Yes, and it can lead to death. If the fluid is pressing, would that also cause the fontanelles, the soft spots of the head, to be bulging out? So hydrocephalus, how do they treat it? They put in shunts that drain the ventricles, and these shunts will be draining internally into the baby and taken back up by the heart. And so hydrocephalus, nervous system disorder. Next one we have down here is spina bifida. This is the one that we've talked about quite a bit. This is also a congenital neural tube defect. So what happens here? And it says the vertebral spaces fail to close. So your vertebrae are what? Bones, and they should be, the spaces there should be closed. In this case, they do not. So what happens? There's a bulging, also called a herniation, a bulging of the spinal contents into a sac. When we talk about the spinal contents, we're talking about what? The spinal cord, the actual nervous tissue. So the spinal cord, the nervous tissue, has a lining around it, a covering around it, an outside part. And we talk about the meninges. So the meninges that covers the spinal cord, it herniates through the vertebral space, and it is called a meningeocele. Not a good thing. So if the spinal cord and the meninges around it, if they herniate and go out and make this protrusion on the outside of the body, it is referred to as a myelomeningeocele. I said that wrong. Myelomeningeocele. I was thinking of myo before, which is muscle. When we talk about myelo, M-Y-E-L-O, we're talking about the spinal cord. So they can do surgery. Once again, it depends on how bad this is, as to whether it will be something that would affect the baby or the child, adult, whatever, the rest of their life. So yes, on some of these, it can cause problems, for the rest of their life. Okay, anencephaly and microcephaly. Both these, they're saying that part of the brain is missing. It is not there. The skull is flat, and many times the newborn only lives for a short time, or is stillborn. So depending on the extent of this, it may have very serious problems. So it depends on the deformity, the extent of it. So they would be, if they did live, they would be mentally retarded. Okay. Cardiovascular disorders. So it's better, I know on one of these I gave you a video that you could go to look up. So I'm not getting all into this because it's a little bit hard describing all this without pictures and so on. Okay, so cardiovascular defects include, first one we see there is a patent ductus arteriosus. So that would be a bad thing. We do not want it. In fact, it was in the fetus. It was a duct, and it was called a ductus arteriosus. At birth, we want that to go away. We don't want that to be there anymore. So it should close at birth. It is going to become a ligament. Another one is atrial septal defect. So when we talk about atrial septal defect, we know that it has to do with the atria, because that's what it says. Septal, we know that it has to do with the septum of the heart, and a defect. So what can go wrong here? What's the problem? We also actually have a ventricular septal defect. Same thing. It has to do with the ventricles and the septal wall. So there is going to be abnormal openings between these chambers. There should not be an opening. But if there was a defect of the septum, that's what we're talking about here. When we talk about petrology, we're talking about 4 major heart defects: pulmonary stenosis, ventricular septal defect, overriding aorta, and hypertrophy of the right ventricle. This is, so they just named it this because there's several things at one time. We also have what? The aorta, it may be narrowing when it leaves the heart. If it narrows when it leaves the heart, what does that mean? Would that mean that the heart would have to what? Pump with more force to overcome that higher pressure? So what you really need to know for all of this, for a baby that is born with a cardiovascular disorder, cyanosis, blue, not enough oxygen. That's one characteristic feature, a blue baby, right? And when the baby cries, it's worse. Oh, look, it's getting more blue. The more it cries, the more blue it gets. Okay, would that make sense? Does it take energy to cry? Is it hard to breathe and cry at the same time? So they always listen for heart murmurs on a newborn to see if there is something that they can hear. They always look for color. And of course, they're always checking for respirations and any problems with that. So if there was something going on with the heart, basically they treat the baby symptomatically. So what does that mean? They're treating the symptoms. They are giving whatever needs to be given. So they could be giving some medications, and then also they may be doing surgery or several surgeries. So here we have a patent ductus arteriosus. So what are we seeing there? On the left hand, this is what we should be seeing on a newborn. let's say on a newborn, not exactly right at birth. Well, let's start at the other side. That would be easier. It says patent ductus arteriosus. You can see where that arrow is pointing at. There was a duct there that would take the blood and just take it back out to the body, basically. It didn't need to really go to the lungs because what? There was no oxygen being given. But of course, after birth, that whole thing changes. So we don't want to bypass those lungs. We do not want that duct to still be doing that. So usually it will close up, and that's what we would want. We would not want it to be patent. If we have an atrial septal defect, so what this one is showing is what? The atria are communicating with each other, and it is showing that on the right hand side here, an opening. Okay, so genitourinary disorders, bladder exstrophy. So the bladder's on the outside of the body, but it isn't just the bladder. It is talking about some other things too. So the abdominal wall, the urethra, the ureteral openings. So something went wrong, and all of this is on the outside of the body. It isn't just like go in and push it back in. It doesn't work that way. So it says they have to do the reconstruction of this in steps. And it takes a while for all this to happen. They like to have it completed by the time the child starts school. So this is serious. This is very, very easy for them to get an infection when they have this. So just know that the bladder and other parts of the pelvis can be on the outside of the body. Next one we have is hypospadias. And what are they talking about? The urethra opens on the bottom side of the penis. So would this make it more difficult? You have, let's say, a youngster that you are potty training. Your aim would not be very good. So causes problems during toilet training. They can't direct the urinary stream. So they can make use of the foreskin. So they do not want them circumcised right after birth because they need to use that skin. We have another one, epispadias. And this one is what? The meatus is located on the upper side of the penis. So these can be fixed, changed. Gastrointestinal disorders. Well, we have a long list under this one. And remember, I said this could go from the mouth. So we have the mouth, the throat, the esophagus, the stomach, small intestine, colon, rectum, anus, etc. So anywhere in there. So we'll start off with cleft lip and palate. So about one in 1,000 births. So that's about what? 0.1%. Vertical opening in the upper lip. Could be a notch. We also have, if the palate, the roof of the mouth, if that is split, then that's known as a cleft palate. I guess I should have said I was talking about cleft lip first, not cleft palate. So cleft palate would be more serious, and it can be both sides. It can be cleft lip and cleft palate. So one of the things that we're thinking of, like immediately after birth, is the fact is it's going to make feeding difficult. And yes, it will. So they do have special nipples, special feeding devices that will assist in feedings. So surgical repair, and this usually happens when they're fairly young. So cleft lip, cleft palate, that can be fixed with surgery. So we talked about this one too, choanal atresia. Remember what that was? So the nostrils, the nares, it says they're closed and you're taking a deep breath that only gets to what? To the entrance to the throat. And it was just kind of a blind pouch. So they can't take a deep breath. And remember, infants are nose breathers. They have to breathe through their mouth. Through their nose, sorry. They have to breathe through their nose. So it can't just be that they would then, breathe through their mouth if this didn't work out. We have esophageal atresia. And on this one, the esophagus that goes from what? You have the throat, then you have the esophagus, and then it ends at the stomach. On this one, the esophagus also ends in a blind pouch. So the food, the formula, the breast milk is not going into the stomach. So sometimes they will just give total parenteral nutrition or nutrition by IV till they can get this fixed because they cannot be fed anything. We have another one. This is even more dangerous. This one says tracheo, so we know trachea. Trachea is below the larynx. It goes down into the lungs, goes to the bronchioles and then into the lungs. When we talk about the esophagus, that goes to the stomach. If there is a fistula or a tube between the trachea and the esophagus, would that mean that if the baby was, let's say, nursing, that this milk would be going then over from the esophagus into the trachea and into the lungs? Yes, they need to do something immediately. So when an esophageal atresia is accompanied by a tracheal fistula, it's called a tracheoesophageal fistula. The food is going, or the formula is going into the lungs. So the baby would suffocate if it wasn't taken care of immediately. We have another one, pyloric stenosis. This is a congenital anomaly. So in the stomach, we have what? We have two openings. We have an opening from the esophagus into the stomach, sometimes called the cardiac sphincter. We also have an opening at the bottom of the stomach that goes out into the duodenum, and that's called the pyloric sphincter. So what if the muscles around that sphincter were really big and doing their job? Would that perhaps make it more difficult for the pyloric opening to open up and let out the contents of the stomach to go into the duodenum? Food can't get through there. So baby starts out by vomiting, and later that vomit becomes projectile. We heard that. It could go out several feet because the stomach is full. It is full. So usually surgical correction for that. And there are ways by feeding less. So it does depend on to what extent that it has this stenosis. Imperforate anus, they used to do the rectal temp on newborns and they would find out very quickly if the anus, if there was a blind pouch there. because they would be able to tell when they took this. So now they don't do the rectal temperature usually, but they wait till the meconium, if it does not come out within, I think they give them 24 hours. And if it doesn't, then they check and see if this might be the problem. And it is usually a fairly small surgery. We have another one, phenylketonuria, PKU. What is this? This is a genetic defect. So genetic defect, amino acids, something to do with protein. So if you can't metabolize, what does that mean? You get these amino acids and you can't do anything with them, usually because what? You're missing an enzyme. And so there's, you're kind of stuck with them if they're in your body. Not a good thing. So what can happen about this? It says if they can't metabolize these, that they get into the blood and the tissues of the body, the brain, etc., in the form of phenylalanine. So there's no cure, but they can put babies and for lifelong on a special diet. So right after birth, as quickly as possible, they make sure that they are not giving them these particular amino acids. If the baby, or the parents, I should say, do not know about this, the baby wasn't tested, it says it could result in mental impairment, behavioral problems, retardation, other abnormalities. So all newborns are tested for PKU before discharge from the healthcare facility. They also are tested again when the mother goes back to the 6-week checkup. So usually, like I say, on some of these, missing an enzyme that would take care of this. Galactosemia. Okay, so this is something about the blood, anemia, galactose. What about galactose? What is that? Galactose. Okay, milk. Oh, that's right, galactose, milk. It is a milk sugar. So newborn is incapable of metabolizing galactose. And galactose is a sugar found in milk. So galactose, the baby is supposed to break that down into what? Into lactose and glucose. So there are people that are what? Lactose intolerant? So what does that have to do with this? Nothing? So you do need to remember then, galactose needs to be metabolized into lactose and glucose. We need that glucose, right? We need that glucose. The baby's never going to make it to that glucose because it can't metabolize it. So if it cannot be broken down into lactose and glucose, what is it going to do? It's just going to build up in the body. Body can't metabolize it, can't get rid of it. So what's the baby going to be doing? It's going to be vomiting, going to have diarrhea, maybe jaundice, seizures, liver damage, brain impairment, death. This is serious, isn't it? Very serious. And it usually starts a few days after birth. As soon as the little body can't get rid of it, well, it's not going to have any glucose either. How's that going to work? So failure to thrive, infant feeds poorly, vomiting and diarrhea. So hypoglycemia, would that make sense? Hypoglycemia, because there is no glucose, right? So dietary management, having to what? Change from milk to something else. Change to something with glucose in it. Last one we have down here, necrotizing enterocolitis. So we know itis, inflammation on this last word. Go to that entero. We know that has to do with the intestines. And then when we look at that whole thing, colitis, we know that it's going to have to do with colon, inflammation of the colon. When we go to the first word, necrotizing, when we think of that or look at that word, we know that that means what? Death, tissue death, death of tissue, death of tissue in the colon or the intestines. So it says that this is a serious, often fatal disorder of preterm infants. Preterm infants. So for some reason, what? They have their intestines dying off, inflamed. Even if they recover from this, it says they usually have chronic health conditions and disabilities. So another reason not to have preterm babies, right? So bacteria gets into the bowel, and then the bowel becomes ischemic. What does that mean? Ischemic, or blood flow, holding back blood, ischemic. And so because there is not enough blood flow, would that mean there is also not enough oxygen and so on? And the baby then will have an inflammatory disease or condition, and some of the intestines will be dying. It does say bottle-fed babies are more susceptible to this. So NG tube and suction is going to let the bowel rest. NG tube sectioning out, let the bowel rest. So not feeding them with the NG tube, but sectioning and not feeding them that way. So they're going to be getting what they need from IVs. So they probably will have to do surgery and take out the part of the bowel that is dead or dying, that has not had enough oxygen get to it because it doesn't have enough blood flow. Okay, chemical dependency. Wonder if this is true. It says nurses are often the first to observe signs of drug dependency in newborns. Maybe that's because they spend more time with them. So we have things here like fetal alcohol syndrome, cocaine, and crack. So when we talk about substance abuse and mothers of these newborns, substance abuse, we're just saying they're using some drug to excess, and really there's no reason they should be using it. So usually using it for, I guess, their own benefit. So what can this do to the baby? So baby is going to be at high risk for many complications. Many of them are going to go through withdrawal, and this is called, if they are going through withdrawal, neonatal abstinence syndrome. I think we talked about this before also. So going through some of these stimulants, cocaine and methamphetamine. So hypoxia, does that mean low oxygen? Is a leading cause of teratogenic defects, which include severe brain damage, genitourinary malformations. Oh, we did see that. Remember the bladder on the outside of the body? Arm and leg abnormalities, cardiac defects. Preterm pregnancy is very common. Preterm pregnancy is very common. Okay, opioids. Some people still call them narcotics. We used to call them narcotics. They changed that to where narcotics is everything. But so opioids, central nervous system depressants, which we know that, and they are different from stimulants, just about exactly the opposite, right? Make people feel relaxed. So in this, we have things like codeine, heroin, methadone, morphine, and so on. They are addictive. They cross the placenta. So what they're saying is that opioids such as heroin that are present in the mother will also be present in the newborn for at least 2 to 6 days. So we have birth. Now we have like what, 2 to 6 days that this baby still has this in their system. So the symptoms are going to appear shortly after birth, and then they're going to get worse. So I'm not going to go through all of these examples of opioid narcotics, but just to name 2 of them, like hydrocodone, oxycodone. We also have marijuana down as one of these, and this is one of the most commonly used drugs. And of course, now in Oregon, it is legal to buy it and use it. So they don't really know all of the side effects of marijuana on the newborn. They do know that it crosses the placenta. And they do know that smoking of any drug is going to affect the oxygen available to the fetus. And so that could result in a high-risk newborn. Okay, I'm going to skip down to nursing considerations. One of the things that a nurse needs to do is to get the mother that is using or abusing drugs, alcohol, tobacco, etc., to actually tell the nurse, you know, what she is doing, how much she's using it, and so on. A lot of people don't want to do this. So by having a trusting relationship and approaching the mother in a non-judgmental way, they need to get information about these drugs. So even though they say that most symptoms of opioid use are gone in 3 days, talking about the baby, but they can continue 4 to 6 weeks or longer. That's a long time. And sometimes it's saying that a cocaine-dependent newborns have significant withdrawal syndrome. That can last 2 to 3 weeks. So the cocaine-exposed neonate may not show specific behaviors, but is just irritable for several weeks after birth. So for these infants, when we're talking about cocaine, they might have things like increased muscle tone, tremors. And what should we do? They're saying that light, sound, noise must be minimized. Sedation may even be necessary. They do need to be touched. Thinking of bonding, touched, but we keep everything as quiet and neutral as possible. So there may be legal issues that need to be considered in these cases where babies are born, you know, addicted, or babies are born and having problems because of what the mother has used. So going on to this next one, here it is just showing symptoms of, and this is signed symptoms, of neonatal abstinence syndrome. So irritability, jitteriness, tremors, hyperactivity, hypersensitivity, shrill, high-pitched, persistent cry, frequent sneezing or yawning, increased tendon reflexes, and increased muscle tone. Not a very happy baby. Last thing I have here. Symptoms of neonatal abstinence syndrome continue. A decreased moral reflex, decrease. So they're not going to be doing that, throwing up their arms. What about their legs? So know about the moral reflex, because they will have irregular sleep patterns. They'll have feeding problems, diarrhea, weight loss, or lack of adequate weight gain. So addicted newborn is hypersensitive. So I'm going to read out of your book what it says about how to hold them and how to move them. You need to know this. It says suggestions for handling an addicted newborn include providing eye contact, touching the newborn gently, and rocking up and down, not side to side. Okay. I believe I am at the end of this. I'm looking at this last one. I am. That is it. Okay. I'm going to upload these, and the next one you will see will be the next chapter on surgeries, operations, before, during, after. So, and I will also be uploading, let's see, you have one more quiz, week 10, so I'll be uploading your study guide for that too. Okay, I guess that's it for now. Bye-bye.